Well, thank you everyone for taking the time out of your practice to be here tonight. I think you're going to find this really kind of enjoyable, actually. We've got some new thoughts about scleral contact lenses, how they fit into the practice, and how we're going to be utilizing them in practice. You know, today, all of us in clinical practice are faced with a wide range of corneal topographies that we need to manage somehow with rigid contact lenses. And today, when a patient sits down in front of you with an irregular cornea, we actually have three good clinical options for them. Number one is our standard go-to lens, and that's always going to be a large diameter corneal contact lens. We also have in the category of rigid lenses, hybrid lenses or piggyback lens designs, and then today we have this new scleral lens design that is again a viable option to entertain for the patient. Now the major question is, when do I use which and how do I go about doing it? Well, a standard rigid contact lens works exceptionally well when we have symmetry to the cornea. You see, when we're dealing with rigid corneal contact lenses, everything we do is related to height differentials in the cornea, how high the cornea is in a spot and how low it is in other spots. Now here we've got an individual with keratoconus, and we can see here this large diameter corneal contact lens, a spheric contact lens, has been given the luxury of landing here at 9 o'clock, 12 o'clock, and 3 o'clock. Now we have a stable lens fit. We've got a platform on which when we vault the apex of the cornea, the lens has that luxury of coming down and coming to rest on this area here where there is a significant amount of symmetry. So the word symmetry is really the key. Now let's take a look at these topographical maps. Here we see a wide range of corneal topographies, and some of these eyes obviously cannot be adequately fitted with a corneal contact lens because of that differential in high versus low spots. When we put these corneal contact lenses on these eyes, what we end up with is areas where the cornea is the highest, because that is where the lens is going to first come in contact with the tissue, and then where the cornea is the steepest, has the greatest amount of curve, the lens is naturally going to lift off. When you have these kinds of asymmetry, it's almost impossible to get a rigid corneal contact lens to be stable on the eye. It doesn't have that luxury of landing on that symmetry in the cornea. So there are a lot of individuals with these kinds of topographies. Now let's take a look at this patient. Obvious diagnosis here would be pellucid marginal degeneration. Now, you have to ask yourself kind of a fundamental question. Where is the cornea the highest and where is it the lowest? Because we know where the cornea is at its highest altitude is where the rigid contact lens is going to come in contact first. Now, most clinicians today will go, well, the cornea is highest here. The reality is that's where it's the absolute lowest. Now, let's show you how you need to visualize corneal topography today. You need to be using what's called the elevation display map. What that does is it takes a theoretical spherical surface and then tells you where the cornea is the highest and where it's the lowest. Where it's highest is where the red is, where it's lowest is where the blue is. This is why when I apply a spherical contact lens onto that eye, it's going to hit first where the cornea is the highest, here, where the red is, here, and it's going to lift off where the cornea has the lowest depression. So this is how we need to start thinking about corneal shape. You see, what the scleral lens does is it allows us the ability to completely vault over all of these asymmetries in the cornea. Where we have all these different height differentials, it allows us to just completely vault over that area. And this is why these lenses are so exciting for these irregular corneas. Now, let's take a look at this corneal topography here. Obviously, a patient with moderate keratoconus. Ask yourself that fundamental question. Where is the cornea the highest? Where is it the lowest? Well, we can look at our elevation map, and our elevation map says it's actually highest up here and lowest down here. Now, how is that? Well, why is that? Because the red is indicating here. But what we're actually seeing here is something that is very important. And what it is, it's just an area of more abrupt curve. That's all you're seeing there. So it's actually a part of the cornea that is depressed. It is lower in that area. So now when we apply the contact lens to that eye, the lens has great alignment along this area of the cornea, but notice how much the lens jettisons away from the inferior cornea, because now it's jettisoned far enough away that it's actually interacting with the lower lid. So now this is going to be an uncomfortable lens for the patient. Now we're all aware of the fact that there are quadrant-specific lens designs out there, but my experience with the quadrant-specific lenses has been very, very poor. And therefore, when we see this kind of asymmetry, high here, very low here, that's when we begin to entertain the idea of a scleral contact lens. Once again, the scleral contact lens is going to allow us to vault completely over the central cornea, completely over the mid-peripheral cornea and limbus, and ultimately land on the sclera. Now, we're pretty much aware of the fact that there's a wide range of corneas that are going to have these varying height differentials. And these various pathologies become candidates for these kinds of lenses. However, there is a subset of individuals that become prime time candidates for scleral lenses, and that is this group of individuals, those with ocular surface disease. There is no medical treatment we know of today that can surpass what a scleral lens can do therapeutically for the eye. These lenses become the single primary treatment for managing these kinds of underlying pathologies. So these are really patients that we want to target with these modalities because these contact lenses will be a life-changing experience for those individuals. Now, why all of a sudden in our history of contact lenses are we seeing this rebirth in scleral lenses? There's no doubt that these lenses have been around since 1887, and yet for so many years we just simply negated looking at these as a possibility in our practices. Well, I believe that 3 innovations have really come along that have really helped us to move this forward, to have this renaissance in scleral lenses. Number 1 is sheer comfort. When we do comfort studies at the university, we have the patients grade the comfort scale from 0 to 10. 0 is unbelievably uncomfortable. It's like, get this out of my eye now. So 0's bad. And 10 is I physically cannot feel the lens on my eye. Now, when we do our silicone hydrogel soft lens studies, the average scale reading is a 9. That's what patients feel when they apply a silicone hydrogel lens. Now, when we were doing our scleral lens studies, we looked at 2 different designs, and we found that the average scale reading in non-adapted contact lens wearers, these were not rigid lens wearers, they were not soft lens wearers, these were eyes that had never worn a contact lens before. The average rating of the scleral contact lens was 8.5 at initial application. Now that's amazing. I never thought in my lifetime that I would see a rigid contact lens that has comfort values that are almost identical to that of a silicone hydrogel lens. It has happened. So comfort is something that is unbelievably important. It's important to us, it's important to our patients. The second innovation has been the change in lens materials. We now have high decay contact lens materials that can provide oxygen through these thicker scleral contact lenses. And later on, I'll be sharing with you some of our preliminary work on oxygen permeability through scleral lenses, and I think you'll find that little body of work very intriguing. Yes, we do get oxygen underneath these contact lenses permeating through the plastic. Probably not much through tear exchange, but a lot through the material itself. But I think the most important innovation to take place that has taken this scleral lens modality to the next level has been a new understanding of scleral shape. You know, when you and I were back in school, we were taught by our anatomy professors that the cornea had a curvature to it. Well, yeah, of course it does. But it's important we remember one little fundamental thing, and that is the cornea has a curve to it, but that curve only takes place in the center 10 millimeters. Beyond that, the cornea moves into a straight line or tangent. Secondly, we were taught that the sclera had a curve to it, a fundamental error. The sclera, surprisingly, doesn't incorporate a curve until it gets beyond a chord of around 20 millimeters. That is to say, here is the real physical shape of the cornea, the peripheral cornea, the limbus, and the sclera. We see the cornea with its curve in the center 10 millimeters. At 10 millimeters, that curve comes to a rather abrupt halt, and it forms a straight line or tangent out to the limbus. Now, at the limbus, it actually continues that tangent. We see it so nicely right here in that image. That tangent goes out to 15 millimeters, out to 20 millimeters, and then finally, at about 20 millimeters, the eye finally decides to make its global shape. So, armed with this information from the OCT imagery, we thought that a wonderful way to emulate the shape of the eye as we know it today would be to use a tangent angle scleral lens design. And that's exactly what we have with the ICD 16.5. It has a curve in the center of the lens, but that curve then joins up with a tangent angle. And that tangent angle clears the peripheral cornea, clears the limbus, and then ultimately moves into the scleral landing zone where it comes in contact with the surface of the eye. So virtually all what we do with scleral lenses is related to one word, and that is clearance. We need to clear everything. We need to clear the cornea. We need to clear the peripheral cornea. We need to clear the limbus, and then let the lens land on the sclera. Now, what are we trying to accomplish in the central area of the contact lens? We said the word was clearance. But then again, how much clearance are we actually looking for? What we're looking for is approximately 300 to 400 microns of clearance here beneath the contact lens. The contact lens itself has a thickness of 350 microns. So it's a wonderful ruler on the eye to measure the volume of tear beneath that contact lens. Now, the question is, why do you need all of that clearance? Because when you and I are fitting a standard 9.5 millimeter corneal contact lens, our target amount of apical clearance is around 20 microns. And now we're seeing 300 to 400 microns? That's insane. But there's a method to the madness, and that is when you have a modality on the eye that is clearing the central cornea, clearing the peripheral cornea and limbus, and then ultimately landing on the bulbar conjunctiva, there's going to be some rather significant amount of settling of the contact lens on that bulbar conjunctiva. You see, mistakenly, we call these scleral contact lenses. Well, they don't even come close to hitting the sclera. They're riding on the bulbar conjunctiva. Now, anatomically, the bulbar conjunctiva has a unique surface. It is loaded with these goblet cells. These goblet cells, of course, secrete the mucin for the tear film and do a wonderful job of creating that extra lubricant. However, these cells are extremely compressible, so that when we take the weight bearing and pressure of the contact lens and distribute it across this area, it is going to compress slightly on that tissue. Now, what happens in our studies when we apply the contact lens and we look at that lens after 8 hours of lens wear, we can see that the lens has dropped approximately 100 microns. So very quickly, over an 8-hour period, that lens is going to drop 800. So what maybe started out at 300 or 250 microns is going to decrease as the individual wears the lens. Well, as with all anatomical features you and I deal with every day, there's a wide range in this settling effect. That range can go from 70 microns of sinking all the way up to 180 microns. The average is right around 100 microns. However, in follow-up studies after 1 month of lens wear, we average about 146 microns, or call it 150 microns, of this lens settling. This is why we have to initially overshoot our amount of apical clearance to compensate for that settling effect as that lens comes to rest on the bulbar conjunctiva. So if we start out with a contact lens like this, where we have minimal apical clearance, we're going to run into serious problems. We have to vault the center of the cornea by that 300 to 400 microns to allow that lens to settle in freely on the eye without it impinging in the peripheral cornea or in the central cornea. So we can see here there is an anatomical difference between the fluorescein pattern we see here and here. That anatomical difference is that here there is so much fluorescein beneath the contact lens that it has actually obscured the visibility of the pupil. So when you can see the pupil, chances are you don't have enough vault in the central portion of the contact lens. Now, how do we estimate that at the slit lamp? Well, there's a sure way to do it, and that is with optic section of the slit lamp. Such a wonderful, wonderful tool to have. What you'll do is narrow down the parallel pipette. You're going to visualize the thickness of the contact lens. When you see that same volume of tear beneath the contact lens, you can rest assured that you're in that vicinity of 300 to 400 microns of apical clearance. Now, we said that beyond the central portion of the cornea, it goes into a straight line tangent. And here we see it anatomically, and here we see why the incorporation of that tangent angle. Now you got to remember, many manufacturers have designed their scleral lenses with radii of curvature. And the problem with radii of curvature is that they always move in towards the surface of the tissue. The beauty of a tangent in this case is that it very much emulates the shape of the peripheral cornea and the sclera. Now, that means that when we're visualizing a scleral lens, there is a very important area for us to look at, and that is the area beyond the corneal boundaries. What we want to see here is fluorescein bleeding over beyond the limbus onto the sclera. What that tells us is that we indeed have clearance in that area of the contact lens. We can see it best, believe it or not, with fluorescein and white light, because now we can make out the boundaries of the cornea and how that fluorescein is going to bleed over. Now, how do we know when we have insufficient clearance in that peripheral cornea and limbal area? Well, it's so simple. What you'll see is a darkened area in that area of the anatomy, and when you see that, you know you have limited volumes of fluorescein underneath that portion of the contact lens. And here is what we ultimately want to see. We want to see the lens, the fluorescein going beyond the corneal boundaries, telling us we do have adequate limbal clearance. Now, one of the more common adjustments you're going to make with the ICD lens is in the angle of this limbal clearance curve. We can see here that we have a limbal clearance curve that is virtually touching or aligning the peripheral cornea and the limbus and sclera. So now what we want to do is we want to change that in 5-degree increments. That is, we're going to take that scleral, the limbal clearance zone, and we're going to increase it +5, or a 5-degree change. And that is going to lift the contact lens up off of the peripheral cornea, up off of the limbus, and it's going to increase then the actual sagittal height of the contact lens by 125 microns. So you can see here the lens has minimal clearance. By increasing that angle 5 degrees, we now clear the peripheral cornea and limbus, and now we raise the lens 125 microns. This illustrates a 5-degree change in the design of the lens. Here we see a lens with minimal peripheral corneal clearance, and now with that 5-degree change, we've now got the desired limbal clearance that we're looking for. Now, we do have to remember that there are some anatomical differences in the shape of the sclera. That is, our recent studies at Pacific University have found a rather intriguing anatomical difference between the temporal sclera and what's occurring on the nasal side. Now, I'll get into this in a little more detail later, but what you'll notice is that when you apply a scleral lens to the eye, the lens is going to land first on that nasal side. Why is it going to land first there? It's because this area is actually higher up. It's elevation. Everything we do with contact lenses is elevation, how high or how low. When this is slightly higher on the nasal side than the temporal side, which by the way it is in 100% of humans, it's just the way the extraocular muscles insert that create this slightly elevated area here, we're going to see a little bit of thinning on that nasal side. So here's a great example of this. We see a patient's left eye. We see we've got nice limbal clearance on this side. However, we're seeing a little bit of thinning superiorly and over on that nasal side, Because remember, when the lens is applied, it's going to come in contact first on that nasal side. Now, don't panic. We don't need to increase that limbal clearance zone 5 degrees. Because now what I'm going to do is I'm going to instruct the patient to look over this way towards me, and now we see the lens has great limbal clearance. We have the patient gaze in all 4 directions of gaze, and we see what looked like to be a tight area up there. When the patient gazes down, fluorescein does come across that area. So it really is just a slight anatomical difference in the peripheral cornea, or in the sclera. So have that patient make those excursions and make sure we're getting clearance of the contact lens in all 4 quadrants of gaze. Now, here is a patient that would benefit from that 5-degree change. You'll notice here that on the nasal side, we seem to have fluorescein thinning. I'm not going to panic there, but I'm following that thinning up, and I'm seeing it's going all the way around and even somewhat visible on that temporal side. So when I see that area of touch covering an area of greater than 180 degrees, that's when I begin to entertain the idea that I'm going to want to change that peripheral angle 5 degrees and simply open up the periphery a little bit more. Finally, the lens has to come to rest somewhere on the eye, and that is going to be in the area of the sclera. So here we see the lens coming to rest on the sclera. Now, that area is extremely important because all the weight, pressure, bearing of the scleral lens is going to come to rest ultimately in this particular area. So the way that edge was designed is very important. This is where the bulk of our research was directed. What is the optimum contour to take that tangent angle and bring it into this area where it can once again depart the surface of the eye? So what you need here is what we refer to as a concave radius. A concave radius comes down and then up. And that's exactly what you need on the sclera. If it's convex, it's going to move in towards the cornea, no matter how flat that radius is. So we need that concaved area out there. Now, this is why when you're fitting scleral lenses, you'll want to apply the contact lens and then let the patient sit out in the waiting room for an hour, 2 hours, as long as you can. Because what you're going to be looking for on your follow-up is the conjunctival blood vessels. These conjunctival blood vessels need to stay open. They are your benchmark as to whether or not you need to change the angle of that scleral landing zone. You see, here we see a contact lens that is coming down with its angle and then beginning to make its motion up. 50% of the lens edge is above the surface of the eye, 50% is in the conjunctiva. It is actually compressing in that area slightly. There's no way to avoid this with this kind of lens diameter. It's going to find its area of rest and then begin its departure from the surface of the eye. Here is where we run into problems with scleral lenses. We'll apply the contact lens, we'll leave the lens on for 1, 2, as many hours as you can, and then when we view the patient, we see that the periphery of the contact lens has embedded itself into the bulbar conjunctiva. What you need to do here is, if you see any impingement of the conjunctival blood vessels, is you need to communicate this to number 7. What they will do is they will open up that periphery in 1 degree increments. Here we see the edge coming down, it's a little snug, and here would be a 1 degree change in the periphery. That is going to drop the contact lens 25 microns. So you can imagine if you're tight in the periphery, like this, and you go to a flatter radius out there, it's going to drop the contact lens. It's going to drop at 25 microns. So it's a fairly easy number to anticipate. It's a very small amount of sag difference when you're talking about a lens that's clearing the cornea by 300 to 400 microns. If you lose 25 microns, surely not the end of the world, is it? So that is how you're going to think about that periphery. So far, what we have here is we have a modality where we want the lens to clear the entire cornea. We want it to clear the peripheral cornea and limbus as well. And we want the lens to have all of its bearing, not on the cornea, not on the limbus, but have all of its bearing on the sclera. Now, let's go through the fitting, because the fitting of a scleral contact lens is identical to fitting a soft contact lens, believe it or not. What we know is that when you have this particular design, which is the ICD design, it has its area of maximum bearing at a chord of 15 millimeters. From 15 millimeters on, the lens begins its departure and leaves the surface of the eye, and then obviously ends up joining up with the front curve. So the actual fitting portion, where it comes to rest, is at that chord of 15 millimeters. Now, why did I say it's similar to fitting a soft contact lens? Because fitting a soft contact lens is fitting by sagittal height. That is, if you take an 8.3 lens with a 15 millimeter diameter, granted it's bigger, but I wanted to make it the same as the resting area of a scleral contact lens. If you had a 15 millimeter lens and you had an 8.3 radius, that lens would have a sagittal height of 4,482 microns. As we get down to a more normal base curve, back optic zone radius for a 15 millimeter lens, it's 3,910 microns. So fitting a scleral contact lens needs to be based on the same principles. That is, the diagnostic set needs to be labeled in height. How high the lens is, how low it is. And that's what the ICD does. It starts with a height of 3,900 microns, all the way up to 5,600 microns in 100 micron increments. So we can virtually raise the contact lens and we can then lower it on the eye. And that's all we're doing with scleral lenses. We're raising it up, we're lowering it on the eye. Let's take a look at this particular patient. No mystery about the diagnosis. This is an individual with ocular surface disease, in this case, filamentary keratitis. This is an extremely painful condition, but when a patient comes in with filamentary keratitis, I know that the sagittal height of that particular cornea is probably going to be very normal. It's a non-ectatic cornea, it's a non-surgical cornea, so I'm anticipating that the sagittal height, how high that lens, that cornea is going to be within this realm of sagittal heights. And therefore, our go-to lens is this one right here. This is the contact lens that goes on every single patient where I suspect that that individual has a relatively normal sagittal height. One lens, one magic bullet. You can call this lens the 8-6-14-5 lens in your diagnostic set. You know how when you put an 8-6-14-5 on most patients, the darn soft lens looks pretty good? And that is this particular sagittal height lens. So we're going to prepare that contact lens and apply it to the patient's eye. Now we do that by simply resting the contact lens on the holder or with your fingers in a tripod shape and filling the contact lens with preservative-free saline. I'll be saying a few words about this solution a little bit later on, but we use two preservative-free salines. One is Unisol. The other is a hospital-grade saline solution, which is called inhalation solution. It's used for patients in their apparatus at night that have sleep apnea. And they add this saline solution to provide additional moisture for their lungs. But it works really well beneath a scleral contact lens because it's in a unit dose container. However, you got to be a little bit careful. These have no pH adjustment in them. The pH of this solution is 5, whereas the commercial saline solution, preservative-free, has a pH of 7. So if a patient has a little bit of burning and stinging with this one, we switch them to this. Many times they'll apply the lens with a pH balanced saline and go, you know, it's just not comfortable. We'll put them in the pH of 5 and they go, oh my gosh, that's 100% better. So individual patients, especially with the pathologic eye, may find certain solutions a bit more comfortable for them. Now we just simply apply the contact lens up onto the patient's eye with the lens filled with saline solution, and now the number one problem. And that number one problem is universal for all scleral lens fitters, and that is an application bubble. This is where during the application process I hit the eyelid, I hit some lashes, spilled out some of the saline solution. What you need to do here is just simply remove the contact lens and reapply it. Unlike a soft lens where there's a bubble beneath it, you can move the soft lens around and expel the bubble. More often than not, you'll have to remove the contact lens, refill the chamber all the way to the top, and then reapply the contact lens. This is the same patient with the lens reapplied. Now, the next step is, remember, we have this patient with filamentary keratitis, and we're going to apply that 4,200 micron lens to the eye. We're going to see, does that lens have adequate apical clearance, 300 to 400 microns. Now we're going to do that by looking at the contact lens in optic section. When we see the thickness of the tear lens and the thickness of the contact lens the same, it is a really good estimate as to how much central clearance we have to that contact lens. Next, we're going to put the patient out in the waiting room, because now we want to see how much does that lens settle in to that boggy peripheral bulbar conjunctiva. And so we're going to pay very close attention to the conjunctival blood vessels and see if any impingement is present. If it is, we're going to need to change the way that lens leaves the surface of the conjunctiva. And that's a very easy adjustment to communicate to the laboratory. Now, many of the eyes that we're going to be placing in scleral contact lenses have an underlying diagnosis of keratoconus. And we were interested in determining how different is the central cornea, peripheral cornea, and the sclera in patients with keratoconus and those with normal eyes. What we did is a study on 55 normal eyes completely free of any ocular pathology. And what we found was that when we drew a line at the chord of 10 millimeters and then out to 15 millimeters, the height of the anterior segment from 10 millimeters to 15 millimeters was right around 2,000 microns. Now hold that in your head, 2,000 microns. Now we're going to look at 55 keratoconus patients. To qualify for this study, you had to have a minimal apical radius of 650. The average apical radius of the 55 eyes in our study was 5.35 millimeters. So these were not early keratoconus. These were advanced and severe patients with keratoconus with an average apical radius of 535. Now, let's take our keratoconus population of 55 and measure the height of the eye from 10 millimeters to 15 millimeters. That's this area right out here. Here is our keratoconus population. They had a height of 1,970 microns, 22 microns less than our normal population. Now, obviously 22 microns is statistically insignificant, but it wasn't greater. It was less than what we had in the normal population. Now, this makes perfect sense because keratoconus is a disease of the central cornea. It is not a disease of the peripheral cornea and the sclera. This is why when a corneal transplant is performed, that corneal transplant encompasses 8.5 millimeters of the eye. And in most cases, the majority of the conical area gets removed with that 8.5 millimeter corneal transplant. So now we measured the height of the eye from the chord of 10 millimeters to the apex of the cornea, and sure enough, that is where the increased sagittal depth lies. It lies in the center 10 millimeters of the eye. Now, another intriguing measurement that we took was right out here, the angle that forms at the chord of 15 millimeters all the way up to 10 millimeters. We said that that is a straight line or tangent. When we measured the non-keratoconus eyes, the average angle was 38 degrees. 39 on this side, 37 on that side. When we measured the keratoconus eyes, the angles were 38 and 38. Now, what this means, it means something very important to you and I. It means that when we're fitting scleral contact lenses for keratoconus, they have a normal scleral contour. It means all we need to do is increase the sagittal height of the contact lens to clear that additional sagittal height created by the ectatic condition. Now, let's take a look at this patient because it's kind of a neat example. Here we have a patient with essentially unilateral keratoconus. The apex of this cornea is 730. Here it is 525. Now, when we superimpose the cross-sectional views with OCT, and we align them out here in the periphery, we could see that as we move closer to the apex is where that ectasia, that extra height, is actually taking place. That extra height is about 200 microns, exactly what we found here in our study, 217 microns of difference in the height of the eyes. So here again, we can see that there is no doubt that the keratoconus eye is indeed higher. When we compared the overall height from 15 to the apex of the cornea, the normals were 3,680, the keratoconus 3,940, and again a 260 micron difference. Now here's a great example of this. We have a patient with fairly advanced keratoconus, an apical radius here of 450, and here is his OCT image. Now, no one's going to deny the fact that this isn't keratoconus. We see all of the typical changes taking place in this individual. Now, when we measured the height from 10 millimeters down to 15, we had a height of 1,900 microns. Remember, our average eye was how much? 2,000. And so we have a cornea here which is 100 microns less than normal in height. But the height differential here is enormous. So that is keratoconus. Now look at the angle out here. The angle here is 38 degrees, here 37. Exactly what we have in our normal eyes. So what started out as a very kind of bizarre condition, keratoconus, you can see that all of that action, or the majority of that action, is really taking place in the center 10 millimeters. So it's imperative that we have lenses with enough sagittal height to be able to incorporate that area. So now let's fit this particular patient with keratoconus. The patient here at the center of the cornea has a radius of curvature of 72 diopters. God only knows what that is in millimeters. I have to, forgive me, we still work in diopters in the US. An error we have to live with, unfortunately. But it's a steep eye at the end of the day. Here is the OCT imagery of that individual patient, 2040 microns from 15 to 10 millimeters, and here is where all of the sagittal depth lies. Now, what lens are we going to put on this individual? What we have found in our sagittal height studies is that the keratoconus eye in moderate to severe keratoconus is 300 microns higher than the normal eye. So our go-to lens for keratoconus has a sagittal height of 4,500 microns. This is the contact lens that goes on every single keratoconus patient that falls into moderate to advanced keratoconus. Now, I'm going to prepare the contact lens and I'm going to apply it to the eye. This is it, 4,500 microns. Now, is that the ultimate fit? The answer is pretty obvious. No, it isn't. Because this diagnostic lens showed this little area of fluorescein thinning. If I go 100 microns less, this is exactly what it looks like. If I go 100 microns more in height, this is what it looks like. 4,600 microns in depth. Now, is that the contact lens I'm going to order? No. Why? I forgot something, didn't I? The lens hasn't settled. So I'm going to anticipate that after this lens drops 100 microns, what's it going to look like? You got it, right here. It's exactly what it's going to look like. So I'm going to need to overshoot my sagittal height by probably 200 microns to allow for that settling to take place and still have 200 microns of clearance. So my lens would have a height of 4,800 microns. That would be my go-to contact lens. So here is what this lens looks like, that initial diagnostic lens. Here we can see the fluorescein thinning in this area. It may not be touch, it might be just fluorescein thinning, but it will be touch after that lens settles in. So now I'm going to overshoot that by 300 microns and create my sagittal depth. You see, that's how simple it was. I placed a diagnostic lens on the eye, made the decision that quick that I needed additional sagittal height. Now, what about lens diameter? Because this is an intriguing area. What is the optimum lens diameter for a scleral contact lens? And a lot of that is going to depend on the underlying pathology. Here we obviously have a patient with Stevens-Johnson syndrome, and with those individuals there's enough symblepharon formation, a loss of the fornices, whereby they cannot accommodate a 16, 18 millimeter lens. In these individuals, you're going to need a smaller lens diameter. This patient with trichiasis is going to be able to accommodate any lens diameter we want to put on, be it 15, 16, 5, 18, 22 millimeters. Their globe is going to be able to handle whatever diameter we place on it. This is why we've developed a 14.5 millimeter lens based on the same principles of having corneal clearance, limbal clearance, and landing out in the periphery. So this is the same basic principles as the 16.5 lens. It's just that we've shrunk everything down a little bit. Still, our ultimate goal is to clear the central and peripheral cornea. So here again is another one of those modalities that you can use when the 16.5 is inadequate. Now I said I would mention a little tiny bit about some exciting work we're doing at the university, and that is in measuring the height of the sclera, both nasal and temporal, superior, inferior. Now I'll just cut to the chase. What we have found in our preliminary studies is that the superior and inferior sclera are very similar in their height. But temporally, the eye is much lower than it is nasally. Now we suspect that this has to do with the insertion of the extraocular muscles. When we look at the pattern by which these muscles insert upon the eye, they are closest to the limbus on that nasal side. And perhaps that is what is influencing the height of the contact lens, or the height of the sclera. Therefore, when you apply one of these scleral lenses, don't be surprised if you see a little bit of fluorescein thinning on that nasal side. It's going to look very different from what you see on the temporal side. It has to do with that height differential. You're probably wondering, why is this a little bit darker? Well, that goes away as soon as you touch the bottom of the lens and lift it up a little bit. You know, these call them smaller diameter scleral lenses tend to drop about 1/4 of a millimeter on the eye. And that is the fact that they're just not supported by all of that plastic in the periphery, as you would see with an 18, with a 22 or 24 millimeter scleral lens. So with that 1/4 millimeter of dropping, we do get a tiny area of thinning up here. That goes away when the patient moves their eye with excursion, so it is not a major issue. But you'll always be able to tell the nasal side based on that thinning of fluorescein. Now, I said I would say a few words about some preliminary studies we're doing related to oxygen permeability. Now, this is important stuff because we have to know whether or not these lenses are providing adequate oxygen to the eye. Now, what we did basically is this. We took 6 subjects, happened to be first-year optometry students. We always do our experimental work on first-year optometry students. Right now, today, we're initiating a study in our lab where we're fitting a group of 6 first-year optometry students with PMMA scleral lenses to see how much they swell. And we should get some intriguing results. I'll probably hear the screams over here in England. But nonetheless, it's a wonderful way of studying oxygen permeability. That is to take 6 subjects, measure their pachymetry, their corneal thickness, with the OCT, and then apply the scleral lens to both eyes and then after 8 hours of lens wear, remove the scleral lens and once again map out their pachymetry, how much their cornea swelled underneath that contact lens. Well, we did it on these 6 subjects with an ICD lens and with a 100 DK soft contact lens. So we had 2 materials, both of them with a published 100 DK. One was a 350 micron thick scleral, and the other was a silicone hydrogel soft lens. What we found was that with the scleral lens, the eye swelled 1% on average. With the soft contact lens, the eye de-swelled, became thinner throughout the day with the 100 DK silicone hydrogel lens, following the exact path we would expect. We would expect a cornea to be thickest in the morning when we awaken and then de-swell throughout the day, and sure enough, that's exactly what happened here. Now, how much is 1% corneal swelling? We have to put this in perspective, because when you and I go to bed tonight, we are going to wake up in the morning and our cornea is going to be swelled about 2.8%. That is normal, overnight, physiologic corneal swelling, 2.8%. That's without any contact lens on the eye. Well, when we found that right now we only have 1% corneal swelling, we were very intrigued and very, very happy that we're not quite here. This is where we want to be, but we're in the ballpark. So are these lenses safe from an oxygen permeability standpoint? The answer is yes. They appear to provide enough oxygen for normal physiology to take place. Now I want to just quickly fill you in on a couple other items. Number one is some new innovations taking place in the field of corneal topography that are going to influence how we fit scleral lenses. One of them is right here. That is, with a normal topographer, which is what we have right here, when we do normal corneal topography mapping, we capture data over a chord of approximately 10 millimeters. Now, a number of years ago, a brilliant scientist at the Queensland University in Australia, Michael Collins, he's an OD PhD, perhaps the most brilliant man I know in optometry today. He did some landmark work in what is called composite corneal topography. This is a very simple technique by which you capture the image in primary gaze and then have the patient gaze off 4 rings to the left, to the right, up and down. It goes like this quick when they are moving their fixation. Now what the topographer does in a matter of approximately 1 second, it takes these topographical maps and forms a single composite map. It's using 4th order polynomials. Now I don't even know what a polynomial is, but it sounds impressive. And what it does at the end of the day is it just provides you with a composite map that virtually goes from one edge of the cornea to the other. So it provides, for the first time that we have in history, a composite corneal topography that will go from 9.6 to full corneal topography 11.7. Now here is a patient following LASIK surgery, and following orthokeratology, and you can see the difference in the corneal topography there. Very, very impressive, the extra now data we have. Now, why is this important? It's important because now we have the ability to actually get a very good estimate as to the height of the eye over a chord of 15 millimeters. It's based on this principle. When you do OCT, you get this magic number. That is the height of the eye from 15 millimeters to the apex of the cornea, 3,760 microns. So that is what OCT does. Now, our data from our lab at Pacific University has shown us that as that angle narrows down at 10 millimeters, that is, this angle that forms is a wonderful indicator of how high or low this area is, from 10 to 15 millimeters. The steeper that angle is, the higher that height is. Now, that's not important. What is important is that information is captured with the corneal topographer. The corneal topographer provides us with the height of the eye, and then knowing that here, when we have that angle, that it just forms one continuous slope or tangent out to the periphery, it then allows us to extrapolate the sagittal height. Now, once you have that information, the topographer then can choose a scleral lens to put on that simulated scleral corneal height. Here, the topographer has chosen on this normal eye a sagittal height of 4,400 microns. Why did it choose 4,400? Because it provided 368 microns of apical clearance. But we can see out here at that limbal area, we only have 100 microns of clearance. Now when that lens settles in, we're going to lose that 100 microns. So here we see the actual lens on the patient's eye. We can see on this nasal side our anticipated thinning, but we're actually seeing some thinning out here on the temporal side. So now we highlight the area of that scleral landing or that limbal clearance zone, and we increase that 5 degrees. It picks it up 5 degrees, and now we have significant clearance out there. However, what did we say? We said when we change that angle and lift it up 5 degrees, we increase the sagittal height of the lens an additional 125 microns. So now we're at 514 microns. So we're going to now simply go back to our 4200. We're going to leave the contact lens with that 5-degree angle, and now we'll have 311 microns of clearance. This is where we're going. All this is doing is helping you select the initial diagnostic lens. It's telling you, I can use that 4,200 micron lens, but this happens to be a patient that needs that extra 5-degree change in the periphery. Now, I know that prior to putting on the initial diagnostic lens. If I put on the standard lens, I'm expecting that lens to be a little snug in the periphery. Now, it does not, and it will never replace putting a diagnostic lens on the eye. It just gives you insight into what to anticipate once that lens hits the eye. Now, in the final 5 minutes, I want to share with you a couple of quick case reports. Obviously, no doubt about the diagnosis here, pellucid marginal degeneration. We're all familiar with its topographical differences from keratoconus. And sure enough, when we apply the contact lens to the eye, the lens lands where the cornea is its highest, up on top and down below. So now we have to select an initial diagnostic lens to place on this eye. With medium depth eyes, keratoconus, pellucid, and transplants that have not bulged, we're going to go to our default lens of 4,500 microns. So I'm going to take that lens from the diagnostic set, I'm going to apply it to the eye, and this is what it looks like. Look at the fluorescein pattern carefully and tell me what you might do here. Now, you'll notice that when the patient blinks, there's a little fluttering here down below where it appears that the fluorescein is thinning out. We get some fluorescein thinning up on top also. So here is a contact lens that is 4,500, but since all of the touch is really taking place out here in the periphery, what I'm going to do is I'm going to lift that angle up 5 degrees. And now it's going to increase the sag 120 microns, 25, and now I hope to clear those two areas. Here is that actual contact lens. You'll notice that we've now cleared that area up on top. We now have cleared the area down below. So this is really what you're ultimately looking for. Now we have to let the lens settle in, see how much it drops, and we have to anticipate that and overshoot our apical clearance. I'm convinced I'm going to be okay because as I made that angle 5 degrees steeper, I lifted the contact lens up 125 microns. Now, one more case to share with you. We know that when we put patients with ocular surface disease, this patient with severe pemphigoid, and we leave the lens on, within months, their corneas begin to dramatically improve, both in the amount of vascularization, in the amount of edema, and these corneas go through some remarkable changes. Here is a patient with graft versus host disease, and here is that same eye 3 months after wearing the scleral contact lens. A dramatic difference in both the patient's symptoms and in their ocular appearance. Now, here is a patient with Stevens-Johnson syndrome. This is a patient that had SJS at age 3 and came in to see me at age 26. He had all of the familiar corneal scarring, vascularization, extremely dry eyes, all of the signs, symptoms of advanced Stevens-Johnson. Now, what was interesting about this particular case was that the mother came in with Polaroid photographs of her son in the hospital at age 3 at the acute onset of the Stevens-Johnson syndrome. And here is the patient at age 3. And you can see the amount of pathology taking place around his eyes, his face, and you can see why when these individuals heal up, the majority of their dermatologic pathology is eliminated, but their ocular symptoms last the entire life. Here is his right eye on initial presentation. He had severe photophobia, so much so that he couldn't leave the house. And we put him into these scleral contact lenses. 3 months later, he was perfectly clear, no corneal staining. That was his right eye. Here was his left eye on initial presentation. You can see the ingrown lashes that accompany the condition. Here he is with this scleral lens, and lo and behold, 3 months after fitting him with the scleral lenses, his vision improved from 20/200 to 20/25, which is a dramatic improvement. So much so that he's now got a full-time job, driver's license, and now literally for the first time in his life has an actual normal lifestyle. So these lenses can work some miracles. Here's a patient we just saw a couple weeks ago. Here is his right eye before beginning the scleral lens. Here's the scleral lens on that right eye. And here he is just 2 weeks after wearing the scleral lens. Here he is before and after. His left eye, more corneal staining. And now we put him in this scleral lens. And here is that left eye 2 weeks later. Now again, the only therapy was the scleral lens. This patient had been on maximum dry eye treatments, preservative-free artificial tears, Restasis, everything, and everything failed. 2 weeks in the scleral lens, and this is one of the happiest patients. So you can see why we're so excited about these scleral lenses. These lenses offer each one of us the opportunity to take patients where we have those dramatic height differences in the cornea, and it allows us to just simply vault over it. That's all these lenses do. They're nothing mysterious. They're nothing magical. The results we get are magic, but the actual design of the lenses is designed to accomplish just those things. Clearance of the central cornea, clearance of the mid-peripheral cornea and limbus, and ultimately that lens resting on the sclera. So a lot of work has gone into these lens designs. It has taken us years and years to develop this kind of technology, and here it is ready to go. So my closing remarks are that this is well within the realm of any practitioner out there. Our first-year optometry students are fitting scleral lenses with the same degree of accuracy I can fit them. Just simply going through the process and dealing with these eyes with this vaulting mechanism in mind really is an easy one for them to get their arms around. With that, thank you very much for your attention, and we'll have a little break, and we'll then answer any questions in the back. Thank you very much.